of the accommodation and transport from their own funding. At national level, we've done quite a bit of expenditure already on communication of COVID, and some of these funds will go towards that. The ICT needs for COVID-19 is also quite huge, and we have a number of solutions on track and trace and other IT solutions, and we would like to fund that as well for the COVID-19. We're looking at purchasing quite a bit of buffer stock for provinces, and we are in the process of finalizing a warehousing tender, which is actually closing today, for us to be able to clear and to properly account for our buffer stock, and including in this would then be any donations as well. Port health services, quite a huge area for us, and COVID-19 has given us the opportunity also to recapacitate environmental health officers and port health services. And there's also a portion of the Cuban Brigade at the National Department of Health, which will be funded from this allocation. Next slide there. So just to give you an idea of the reprioritization of the funding, as I said, the direct conditional grant from the NTSG, about 297 million was reprioritized towards COVID activities. This remains within the grant. It does not come out of the grant, but it will be redirected towards COVID-19 activities. And in the main, would probably go towards the issue of ICU beds and some isolation. The HIV grant, 604 million, was reallocated. Mostly, this one would cover part of the PPE requirements. And again, this remains within the grant as to still allow provinces flexibility, but it would form part of the COVID component. Within the direct facility revitalization grant, about 1 billion across provinces was redirected. And Chair, just to say that we have allowed provinces to input into this, and most of these reallocations or reprioritizations are based on their recommendation and based on their needs. And then there's some small amount of national health insurance grant that's also part of the direct grant, about 22 million that was redirected. On the indirect conditional grants, 538 million was reprioritized towards the COVID activities, and I'll speak about that now. And then from our vote funds, about 101 million was identified, which gives us a total reprioritization as per the allocation letter of Treasury of about 2.66 billion. Next slide. So, Chair, the 2.8 billion or the additional funding that was received, ring-fenced money for the Cuban Brigade of 283 million was provided. The general funding, as I said, which would go to the elements that I've described, about 2.5 billion. And then there was a specific allocation to the NICD for 96.7 billion, which would then form part of the transfers to that under the NHLS. Next slide there. This slide just tries to illustrate where we sent where the money was reallocated to. You can see that from the Revite grant, 420 million was reprioritized. It was reprioritized in this case to voted funds and to the COVID-19 component, as well as to field hospitals. On the non-personal services component, we've reprioritized within those three subcomponents, reprioritized towards the voted funds, and that would then, to a large extent, take part or take care of the ICT reprioritization amount. In the personal services component, the GP contracting component, 80 million was moved to voted funds as well to deal with some of the PPE buffer stock. And the voted funds remain within the voted funds. So if you look at the breakdown, earmarked funds of about 411 million was reprioritized towards, and also within the HIV direct grant, and then obviously for the field hospital within the health facility revitalization grant. Next slide, please. So just to confirm, the reprioritized amount within the HIV grant of 604 million, plus the funds from the indirect grants to the COVID component, and the new funding of National Treasury would then all of this would go into a conditional grant for HIV and AIDS, but with a specific component of COVID-19. The provinces, Chair, have to submit to us business plans for this, and we will have to evaluate the business plans in terms of the proposed or earmarked funding. And those business plans are expected by the 31st of July from our provinces, and then we'll be able to reconcile further and see which elements have been contained within that conditional grant allocation. Next slide. So, Chair, as I said, just in terms of the way forward, we'll have to collate the Provincial Department of Health's final revised budgets and allocation letters for the 15 billion. We've got some indications from Gauteng and Eastern Cape so far in terms of what they've allocated, but we need to evaluate the allocations by provinces to see how the additional 15 billion was reallocated. On this point, it's maybe important to note just that provincial departments of health were not spared any reprioritization amounts, that they were also required to contribute to the reprioritized amounts within provinces, but the intention is that they will receive at least that amount plus additional amounts back into the equitable share, and this will then be complemented by the conditional grant that I've just described. Next slide, please. So your brief asked for some service delivery implications. So on the HIV program, there might be some delays in the initiation of patients into the treatment and the care leading, which might require a high level of care of recovery. We've tried to mitigate this by keeping the allocation within the HIV grant, and if provinces are able, or if provinces need to reallocate within the grant, then we at National could still consider a change in business plan. So there is some flexibility within that. Postponement of circumcisions might also affect the prevention program, and there might be some monitoring of the various programs might be affected, and there is a risk of regression. But as I said, we've kept the funds within the HIV grant, and provinces still have flexibility. On the infrastructure program, there will be some postponement of projects that were in the process of either being constructed or in the process of tendered. But we feel that in the most cases, some of these projects could be delayed, or that the program could be extended to a next financial year. The next slide there. On tertiary services, not a big effect to be experienced, as most of it would go for, it would still be within the ICU units, and that there will still be ventilators purchased or ventilators allowed on this grant. So there's not a big impact on this grant per se. Devoted funds, mostly in terms of traveling costs and meeting costs that we've experienced. There would also probably be some element of looking at the transfers to the NGOs that might also be impacted on this, and they might we'll have to look at reducing some of those allocations if needed. On the indirect grants, there's no real effect at the moment, as we will have to just postpone some of the procurement and the replacement, especially of equipment on the ICT tech and ICT grant to the next financial year, or to a latter part of this financial year. Next slide. So there is a grant framework in place for the COVID-19 guiding provinces on utilization of the funds. We've established this grant framework together with the National Treasury. Provinces are developing their business plans, and we are assisting them to do this. And this would be, and we would obviously this would form part of our monitoring and evaluation of the grants every quarter. The IOM tools, India monitoring tools are still applicable, and variance reports will be utilized as monitoring tools. And we do grant reviews at least annually with provincial departments of health and National Treasury in terms of the Division of Revenue Act. And there is a proper testing that done to ensure the validity of transactions and compliance. But obviously, Chair, this would put a bigger strain, at national level as well, in terms of the monitoring and evaluation of conditional grants. Next slide there. Thank you. There are some savings within the Q1 due to the reduction of headcounts and patients visiting facilities. Certain services were suspended and is now gradually being opened to ensure continued service. And it's also done to avoid patients regressing and leading to increased number of mortalities. The cost implications of dealing with complications will be then referred to a high level of care of treatment. And there's also a focus on basic infrastructure maintenance to keep an acceptable condition of the facility. So when it comes to infrastructure, the aim and the focus would then probably be more on maintenance than on new facilities to be established. Next slide. So, Chair, in terms of broad-based black empowerment, we're using the Provincial Procurement Policy Framework Act. And also looking at incorporating the broad-based black empowerment by allocating preference points to companies and service providers. This is still within our procurement process. We do identify on the central supplier database and apply the issue of point scoring when we deal with quotations and with tenders. And we also, another strategy used by us is to advance the BBBE empowerment by using empowerment clauses entrenched in the Provincial Procurement Policy Framework Act, and which allows government departments to pre-qualify bidders to advance designated groups as stipulated. We're also looking at, Chair, the BTI National Treasury to empower more the local manufacturers, and it's part of the National Treasury's instruction. But there is some challenges in that, and we're dealing with that. But when it comes to, for instance, the ventilators, there should be no issue in terms of buying it from local manufacturers. There's quite a number that are available. Chair, I'm going to run through this one as well. This is a summary of the non-financial information. And you did request us to look at the Q4 targets achieved. In Program 1, Program 2, those were the achievements. 3.3 million patients enrolled on the CCMD program cumulatively. 3,300 clinics and other medicine storage sites reporting to the surveillance center. Surveillance center monitoring and assistance was accessible to 6 provincial departments of health. There is an early warning system introduced for the medicine stockout systems. The electronic medicine catalog has been implemented. Comprehensive packages for district hospitals have been finalized. And 45 million individual property, individuals from the population has been registered on the patient beneficiary register. Program 2, there is a provincial malaria elimination plans would have been developed. 80 million tests have been done, HIV tests. Quality improvement plans have been developed. I'll not go through all of them. Program 4, district hospitals conduct ideal baseline assessments. There's also 1,100 PSC facilities that achieved ideal clinics. Program 5, 37 facilities compliant with infrastructure norms and standards. National Health Regional Health Strategy was published by the Department of Health's website. The NHI Phase 1 evaluation has been assessed. And then the biennial conference progress, 5 health entities and 6 territory health professional councils have been produced. And I'm sure Dr. Gail Andrews can also elaborate further on this. The next slide, please. So some actions taken to just improve the performance, to make sure that the case management system for medico-legal claims will be rolled out in this current financial year. It's quite an important program for us. The parliamentary processes for the NHI bill has been extended and is still ongoing. The work on training of the implementation of NHI will continue in the next financial year. The DHMOs will handle it as part of the NHI bill development process. We've consulted provincial HODs and approval on the national guide and conducting of patient experience and care survey at the technical NHC level. The improvement of the male circumcisions transversal contract will be extended further in the 27 PEPFAR supported districts.
For you, I will be doing my
laboratory services will be prioritized, and the outstanding cases of the Criminal Justice Services Reform Committee in the financial year. The NAPISA bill was delayed, but it will be established as a public entity, and its board should be promulgated going forward. We are still looking at provincial health departments to secure budgets and ring-fence budgets for non-negotiables in the next financial year. And then the full allocation of funds for psychiatric health consultations and mental health services. And Chair, we've made quite a bit of progress on this in the last financial year in terms of assisting provinces with this matter. The next slide. So I'm not going to go through this slide. It's just to show the impact statement. Life expectancy of South Africans has to be improved. And then the universal health coverage for all South Africans progressively to be achieved. And this just relates to the strategic plan, the MTSF and the presidential compact commitments that have been made. Next slide, please. So, Chair, just to reiterate that some of the indicators to accommodate the COVID-19 some indicators have been either removed or have been combined with others in program 1, for instance. The conditional grant of health reviews would have been combined with the review of the provincial equitable share formulas. Also the one of reduction in audit qualifications for provincial departments of health. So we've given us support. It's difficult for us at national level to influence all the audit qualifications at provincial departments of health. Program 2, National Accreditation Framework, the PhD facilities. District indicated the 35 clinical development hospitals indicators.